Good morning. Good morning, everyone, and welcome to another episode of This is Revolution Podcast. I am your host, Jason Miles, and as you will hear with this episode, this is our episode with Dr. Eric Osgood. He is a medical doctor. Usually when we say doctor, it's always someone that has a doctorate. We actually spoke to a medical doctor today, and we had a conversation about strategies for Medicare for all. A lot of the first hour, I'll be honest, is kind of the history of Medicare for all, or not Medicare for all, the history of Medicare as we know it today, and a lot of the obstacles that doctors deal with, and kind of the neoliberalization of medicine, as Dr. Osgood will tell us about in the episode. Sadly, in this episode, my co-host, my homie, my dog, Pascal Robert, was not able to make it. He had a day off. He's a hard-working man. If you are checking him out, he is making the rounds on all the news networks. He's become a bit of an expert that they go to, and we're proud of that. So after doing a few news shows, he had another one to do the next day. He's like, hey, man, like, of course. Tap out. But this was a fun conversation. Dr. Osgood, many people on the show recognized him from his appearance on the Michael Brooks show in the early days of COVID. And he's a doctor of internal medicine. And he told us about, in the bonus patron app, it was actually kind of funny. He was talking a lot about the patients that he deals with that think they know everything because they've read some things on Reddit or the internet. That was mildly frightening. But this was a fun show because we really got into the weeds on the history of socialized medicine in this country. And what was interesting to me in doing the research on this was that this has been a discussion in this country since the turn of the century. This isn't a brand new concept that came along during the Bernie Sanders campaign. This has definitely been something that even several presidents have brought up. This was going to be part of the New Deal at one point in time, but it didn't make sense for FDR. It was going to be part of the Social Security Administration, and that did not happen. There was a lot of pushback from the AMA, the American Medical Association. Doctors did not want to be, quote-unquote, wards of the state. They assumed with nationalized health care, it would destroy private medicine, thus making them state employees. Didn't like it. Pushed back real hard against it. And at the time, the cry was not healthcare. The cry was, what do we do with these people that can't work? If you get injured on the job, especially if you work in a factory, this is the mid-30s we're talking about, what about your family? How are they going to survive without the wage earner? So the thought was sickness insurance, the initial title that they were rolling out. Right? So fun discussion. We definitely get in the weeds on this. If you want to watch these shows live, the best way to do it is YouTube, youtube.com/This is Revolution Podcast. And it's every Tuesday and Thursday at 6 p.m. Pacific time. And we've been rolling out new shows, the This is Revolution Presents shows, which have been pretty cool to expand the This is Revolution universe. And we just recently dropped another new one, which was Jean Bajlan and Derek Varn are going to be doing a show about tabletop gaming. And we opened off the show, we kicked off the inaugural episode with Dan Larson of Toy Galaxy fame. And if you don't know about Toy Galaxy and you're in my age group, I'm 44, you're a child of the 80s and possibly 90s, one of the best shows about pop culture, if not probably the best show about pop culture, is Dan Larson, Toy Galaxy. If you liked that, was it called I Love the 80s, the Netflix thing, or Toys, something about toys of the 80s? Dan really gets into the weeds on that stuff, much more so than that show, where they kind of almost make fun of the fact that, you know, these cartoons that a lot of us held dear were just 22-minute adverts. He really gets into the weeds on that, and I think from a left perspective, you know, Dan has been on the show before a few times. He definitely is a friend of show, so that was a fun kickoff show. We do Masha and the Bears, which is a deeper dive, more from an academic perspective than we do on foreign policy. And also the Pascal Robert Mau Mau Hour will be dropping on Wednesday. But if you want to participate, the only way to do that is become a patron. That music is my cue. Thank you guys for listening. Thank you for sharing the show. This is our episode with Dr. Eric Osgood on strategies to get us to Medicare for all. And I am out. Good evening, everyone, and welcome to another edition of This is Revolution Podcast. Before I get started, if you guys haven't checked out our co-host, my homie, my dog, Pascal Robert, has been making the rounds recently on the Black News Channel, and he's going to be on another show. I can't remember the name of the other show he's going to be on tomorrow morning. I'll find out, and I'll let everyone know. Hopefully before the show is over. You know, there's a lot going on with Haitian refugees. He is now the Haitian refugee expert. So, unfortunately, tonight, Pascal will not be joining us, but I think I have a very suitable, I wouldn't say replacement, fill in, if you will, from the mythical land of Iraqistan. Mean Jean Bajlan.
Good evening, Jason. Good evening, chat. Hope everyone's doing well. Lovely to be with you here this evening. Hot off our inaugural episode of Gaming Materials with Derek Varma. We had a great opportunity last night to speak with Dan Larson of Toy Galaxy about Dungeons and Dragons. So, people, if you missed that, go back and watch it because it's awesome.
So, for those that don't know, one of my visions for this thing ever since I started it, which will be 2 years, October 19th, has been to expand this channel to be a bit of a universe, if you will, with a lot of different voices that, of course, aren't just mine or Pascal's. And when we started thinking of who was going to have a show, so we host producer Forrest's Movie Night Extravaganza. We also host Masha and the Bears, which is Maria Replikova's show, which is even a deeper dive into foreign policy issues with people that actually come from academia and think tanks. I would say deeper than what we do on even this show. What would you say, Gene?
I think it's a little bit different. I think, we're kind of, I think Maria is definitely coming at it from the more academic side. So it's a little bit more, I think, academic orientated, which I think it's good for everyone to be exposed to. We all have our political preferences. We all have our political orientations, but I think it is helpful to listen to people who have serious expertise in the field, even if we don't agree with them.
And also, we do a show about gaming, and we got to have one of my favorite people. I love it whenever he gets to come on the show. It's Dan Larson. He hosts a very fun pop culture show called Toy Galaxy, where he talks about cartoons and just all kinds of pop culture stuff from the era in which we both grew up in, which would be the 80s and the 90s. So those guys talked about Dungeons and Dragons, had a history of that. And it's always, also when you come to this Revolution channel, regardless, there's always going to be a deeper dive in the surface level. And as soon as Marcus wipes the wounds away from his Ohio State Buckeyes losing to the Oregon Ducks, we'll be doing a sports show also once a month on Wednesday. So a lot of good stuff going on. But we have a show. You guys came to hear about strategies on how we get to Medicare for all. So before we bring in our esteemed guest, I made a clip. And what makes me mad too about Pascal not being here, I made this clip with him in mind, because if there is a family that my co-host hates, it is the Clintons.
Well, look at his eyes staring at you above you right there.
This is also a picture of Pascal as a young boy that he decided to put up on Facebook. And I told him it was going to be the background of the episode. And he said, no, it's not. And I said, you put it on the internet is forever. The internet never loses. Long live the internet. So this clip was made with Pascal in mind. I hope you guys appreciate it. Take a look.
Oh, if you were to follow a busy doctor as he makes his daily round of calls, you'd find yourself having a mighty busy time keeping up with him. Time out for many men of medicine usually means just long enough to enjoy a cigarette. And because they know what a pleasure it is to smoke a mild, good-tasting cigarette, they're particular about the brand they choose. In a repeated national survey, doctors in all branches of medicine, doctors in all parts of the country were asked, "What cigarette do you smoke, doctor?" Once again, the brand named most was Camel. Yes, according to this repeated nationwide survey, more doctors smoke Camels than any other cigarette. Why not change to Camels for the next 30 days and see what a difference it makes in your smoking enjoyment? See how Camels agree with your throat. See how mild and good tasting a cigarette can be.
I don't get it. Congress isn't passing the health care reform America wants.
Problem is, they don't get it.
We've been clear about the reforms we want.
Private health insurance we can all have even if we've been sick. Coverage we can keep even if we change or lose our jobs. Coverage we can afford.
And why can't Congress write a law like that?
That's a very good question.
Nothing has shined a light on the crisis in institutions like the arrival of COVID on the American shores in late 2019. Between administrative blunders and an overwhelmed hospital system, the United States private health care was no match for the virus. When the then presidential hopeful Joe Biden was on the campaign trail during the Democratic primary, he ran on adding a public option to the already existing ACA. Can COVID finally be the gateway to socialized medicine in the United States? What is Medicare for all, and is it really an end to the for-profit healthcare system? We'll ask these questions and more. This is Revolution.
On September 1st, 1964, Senator Barry M. Goldwater interrupted his vacation cruise and headed for shore in a big hurry. Destination, Washington, D.C. He arrived just in time to cast his vote. No. Then he turned around and headed back. Senator Goldwater flew across the continent twice, almost 6,000 miles, to vote against a program of hospital insurance for older Americans. As he said in the Atlanta Constitution on January 26, 1963, I've got my own Medicare plan. I've got an intern for a son-in-law. Flip answers do not solve the problems of human beings. President Johnson wants a program of hospital insurance for older Americans. He is determined to see this program passed in the next Congress. Vote for President Johnson on November 3rd. The stakes are too high for you to stay home.
Hi, Louise. How was your day?
Well, fine, Harry, until now.
Gee, Louise, you look like you've seen a ghost.
Well, it's worse than that. I've just read the Clinton Health Security Plan.
Healthcare reform sounds like a great idea to me.
Well, I know, but some of these details sure scare the heck out of me.
Like what?
Well, like, for example, it says here on page 3,764 that under the Clinton Health Security Plan, we could get sick.
That's terrible.
Well, I know. And look at this. It gets worse. On page 12,743, no, I got that wrong. It's page 27,655. It says that eventually we are all going to die.
Under the Clinton health plan? You mean after Bill and Hillary put all those new bureaucrats and taxes on us, we're still all gonna die?
Even Leon Panetta.
Wow, that is scary. I've never been so frightened in all my life.
Me neither, Harry.
There's got to be a better way.
Someone asked if that was a weird SNL skit. No, it is not. It was
Bill was using all his acting chops right there. All his, I mean, when he's saying to, he's like, he must be a good actor, because he's telling Hillary that he's not doing immoral things with the interns. So we see where he gets his acting from.
I had to watch. So all these presidents have their libraries uploaded to the net. So I kind of stumbled upon the Clinton one. I wasn't looking for it, actually. I was going through LBJ stuff to find ads, and they actually had the majority of the campaign ads that LBJ ran, some raw footage uncut, but most of the ads that ran. And a lot of those ads were actually 4 or 5 minutes long. And it's real interesting to go from the Clinton campaign where every ad was 30 seconds. You're still thinking in the mindset of you have to get your point across in 30-second sound bites. And when you go back to the LBJ ads, which was a very, important, he's running against Barry Goldwater. These were long, monologues that actors would have. And sometimes actors would be portrayed as Republicans that were upset about the fact that Barry Goldwater, A, was going to drop an atomic bomb, was the fear at the time, and B, that he was just so against these programs like Social Security, which had been in existence for 20 plus, over 30 years at the time, and definitely was not on board with any sort of nationalized healthcare. So let me bring in our guest. He is a doctor of internal medicine. You may know him from the Michael Brooks Show. He made quite a few appearances on several shows recently. Dr. Eric Osgood.
Really, thanks for having me. Great to be here, gentlemen.
Good to have you.
I thought it was funny. You go from Goldwater to Goldwater girl Hillary Clinton, and I was struck by they chose the name Leon Panetta. I imagine they were sitting there like, what random person can we choose? I think he was the CIA director back then, wasn't he? And I'm just wondering if they were going through their Rolodex, and I just wonder if they thought of like Jeffrey Epstein.
That would have been good.
Because no one
could die.
Even Jeffrey could die.
Even Jeffrey Epstein?
Jeffrey Epstein, my good friend.
The Clinton healthcare plan could kill Jeffrey Epstein.
The reason why
I think we all know the Clinton healthcare plan did kill Jeffrey Epstein, right? Either that or the Prince Andrew healthcare plan.
So, Bill and Hillary's healthcare plan, I think, was 1,300, almost 1,400 pages. And it had, when it first rolled out, it actually had bipartisan support. But after a few months in, it kind of died in Congress. And that was their response to their healthcare plan. If you watch all those ads, and I don't know, Gene wasn't living in the country at the time, and I don't know if Eric is old enough to remember those 90s ads of Harry and Louise, of this married couple that was having the most hilarious conversations about their healthcare coverage while they're paying their bills at their kitchen table. And most of those ads also are on the internet, and I watched a bunch of them. Originally, that video was going to be like 15 minutes long because there was so many good clips to take from various administrations that have talked about having national health care coverage, but never was able to roll it out for one reason or the other. But one of the things we talk about here on This Is Revolution is we did a show about it with Doug Lane maybe a few months ago, is the crisis of institutions. The Americans don't trust institutions. So having some sort of nationalized healthcare plan, there is a challenge there.
Yeah. It's funny, you mentioned in the intro, you mentioned how the U.S. healthcare system was no match for the pandemic. As a matter of fact, the GHS index, the Global Health Security Index, would have ranked the U.S. among the top as far as countries best poised to handle it. Within that index, though, there was one specific item where the U.S. scores low, and that's trust in public institutions. So as far as resources and everything else, I mean, even though we have a healthcare system that doesn't rate that high, we have the technology, we have the preparedness, readiness, we have the ability for rapid response, et cetera, et cetera. Of course, we have the broken, non-universal healthcare system, but even then, we didn't rank that abysmally. But yeah, the one score within the GHS index where we were really bad was just like, we have a public that just does not trust public institutions very much. And we saw that despite having a high overall score, they may have to reconsider the weight that they give that one item, because we saw what happened.
Well, we also don't. I feel like when you have presidents, and it doesn't start with Trump, right?
Mm-hmm.
Reagan was real big about shitting on institutions. When you have presidents that have no faith in institutions and always look to the private sector, because the private sector can do it better. I think with Reaganism, you get the rise of libertarianism. Make sure I say that right. Because there's so much faith that the private sector will save you. But, in doing this research for the history of Medicare for All, I mean, initially, and I don't know if a lot of people know this, initially, the United States in the early 20th century was talking about having, actually as early as the late 19th century, we're talking about having nationalized medicine. And there was constantly a pushback, generally from the AMA, the American Medical Association, which is doctors association, that didn't want to be servants of the state. But they later found out, after Medicare finally launched some 50 plus years later in 65, that it was a windfall. But and another reason why we never got any sort of like socialized medicine is when the New Deal was rolling out. Even before that, one of the things people wanted to do was protect workers from lost wages, right? So it was like, look, we can either have this medical coverage, but we need to give people money for lost wages, which ends up being like workers' compensation insurance. And that was even for only a small segment of the population, because if people know about the New Deal, the agricultural sector didn't get it. But that's enough in the weeds. Sorry.
Yeah, so it started as sickness insurance, and then that later became health insurance.
Yeah, that was the original thing. And what I want to know is, what is Medicare? What is the definition of Medicare?
I mean, I guess it's basically, it was born out of the Social Security Act, and it basically means that as opposed to Medicaid, which is covered by individual states and based on income, this is a system of publicly funded care that's given by definition to anyone once they hit the age of 65 or is determined to be disabled, end of life hospice, or end stage kidney disease. And it is basically a system of insurance that is paid for through the Department of Health and Human Services Center of Medicare and Medicaid Services. And once you have it, that pays for your medical care, almost like an insurance company. It's set up almost as a trust fund. And it's broken up into parts A, B. Medicare A pays for inpatient services, so you get hospitalized. Then you have Medicare B that covers outpatient services, so doctor's office visits. In some cases, it'll pay for hospitalization if you're under what's called observation, which is kind of a newer system in the post-Obamacare era, where you're in the hospital, yet they still consider you like you're in the office. And then there's Medicare Part D, which was introduced after 2003, which is basically having to do with prescription drugs. And then Medicare C is like almost like a focused private sector where you can enroll and get you're buying additional insurance through a private company, but it's sort of like an arrangement between the government and a handful of companies, and you can use that to kind of plug up the gaps as far as what your other aspects of Medicare may not cover. So if you qualify, you may have Medicare and Medicaid that'll cover that additional, say, 20% that your Medicare doesn't cover for a hospital stay, something like that. People can buy Medicare Part C, and then that'll cover those additional supplemental costs. So it's just kind of somewhat fragmented, but basically a centralized single payer system over that is it serves as health insurance for those specific populations who qualify. The concept of Medicare for all is whether the services within Medicare can be expanded. So, for example, at present time, it does not without cost sharing or in general cover long-term care. So someone has to go into a nursing home, long-term care facility. Then there's like vision, dental, things like that. So the Medicare for All Act, which was ultimately introduced by Representative Jayapal, I think in May of this year, something like that, HR 1976, that would both expand to comprehensive services, including non-cost sharing, long-term care, prescription drugs, 100% free at the point of service, and then also over a 2-year period start to go to lower age groups and ultimately cover everyone living in this country, which is an important distinction because, you have opponents to covering people here who are not documented, et cetera, et cetera. This would cover anybody living here. So you're living in the United States of America, you're covered, your costs, you have no out-of-pocket costs, your finances are decoupled from the healthcare that you receive. That's the proposition. So Medicare for all is kind of a good slogan because Medicare is very popular, but this is actually much, much more than Medicare.
And can I just ask? Oh, sorry. I just wanted to ask just for a quick clarification. So, at present, the Medicare system doesn't cover everything, though. So you would purchase Part C is basically a supplemental. So whatever care you have some out-of-pocket costs. Is that correct?
Yeah.
So from what I understand, some of the proposals for Medicare for all would abolish those out-of-pocket costs as well. So we're not just talking about the age group of who's covered and the services of who's covered, but we're also talking about ending the co-pays, as you say. So you might purchase Medicare Part C now in order to cover co-pays that you might be hit with if you have long-term care. But this expansion of Medicare isn't simply expanding the existing service to cover more people by age, but also including improving the quality of this coverage by eliminating those co-pays. Is that correct?
That's exactly right. So, especially when you look at things like prescription drugs, dental, vision, and long-term care, that's huge. Because despite having Medicare and paid into the system through your whole life, once requiring long-term care, that can completely obliterate the finances of families. And in some cases through Medicaid, that can be covered. But through just straight up Medicare, you're going to find yourself in a cost sharing system that can really drain resources over the years. So this is something that is going to be a huge relief for many families with either aging or disabled, elders or non-elders in some cases that need, indefinite long-term care.
But if you are pauperized, if you're extremely poor, some of those costs will be hit. Those costs will be covered by the state. But this, I can imagine, is a pretty heavy burden, not on the extremely poor, but on the working poor and on the middle class people, because those kind of costs will drain you in the long will drain you in the long term. If you have a house, all these things have to go up, and you have to basically sell all that off to cover that cap. So yeah. I want to sort of just move focus just a little bit. Can you explain to our audience what the difference is between Medicare and Medicaid? Because I think these words get mixed up in the popular lexicon. Unless you're actually deeply involved in the system, you probably don't know exactly what the difference is. Why don't we say Medicaid for all, for example? Why are we saying Medicare for all instead of Medicaid for all? Can you just give us a little bit of an idea about that?
Yeah, I mean, Medicare for all is somewhat of a misnomer, because what's being talked about is more like Medicaid for all, other than the fact that Medicaid in present day is managed through states, whereas Medicare is managed federally. And so individual states vary a lot in terms of the types of coverage they provide and how they choose to administer their system. And it's basically tied to finance. So if you have to qualify for it based on having low income, being, within X of the poverty line. The other thing about Medicaid versus Medicare from my standpoint, or from sort of a healthcare provider standpoint, is that Medicaid the disadvantage of Medicaid is that it does not reimburse very well for care. With some exceptions, certain state-managed Medicaid systems do, better than others. But overall, you get, higher reimbursements from Medicare than you would from Medicaid. And so this poses a problem to people who get Medicaid, because they can have as hard of a time finding a doctor as people who are either charity care, uninsured, because a lot of private, physician offices don't necessarily want to accept Medicaid patients, because the reimbursement that you get for taking care of them is so low that it's actually difficult to maintain the finances of your office and your overhead and all that, and actually make it worthwhile. And so people on Medicaid often have to find either clinic, charity care clinics, resident run clinics or community health centers, things like that. Much harder in many cases to find the same. So it's like a two-tiered system, which is in of itself pretty unethical and immoral, but that's functionally what happens. Is that people who have Medicaid often need to find specific, generally community-driven healthcare systems that will take them on. And then there's, long wait times for that. And then if you further need subspecialty care, now you have to find subspecialists who will take you, and that can be even harder. So that's one of the disadvantages of Medicaid versus Medicare.
So would you say if we were to live in our perfect world and eliminate private healthcare insurance overall, then you don't have this two-tiered system, but even with some sort of Medicare for all, do you think there still would be some sort of two-tiered system because private insurance would still exist?
Yeah, I mean, I guess I guess the argument for private insurance, I mean, a lot of countries that have universalized healthcare have not entirely rid themselves of the private insurance. But I think, Gene, in your case, like, I think you're probably familiar with like UK, where they do have like these private healthcare networks, but they're very niche. And I think close to, yeah.
I can actually tell, my father was a medical doctor. My brother is a nurse. His wife is a nurse. So they're quite familiar with I'm quite familiar growing up with the system. And the reality is, in Britain, they have a network such as Bupa, which is a private network. But Bupa really doesn't help you that much, because for very sophisticated medical operations, you're still going to be taken to the National Health Service to do those things. So you might get some nice, outpatient care. You might have some simple procedures and operations which are done, quicker than if you were on the National Health Service. But for really, and also this, long-term care that you might get at a private hospital might help you out. But really, for the critical medical issues that you have, you might be in the Bupa hospital, but they'll take you to there's literally a Bupa hospital right next to my parents' house. But if you needed something very serious, they will take you to Hull Royal Infirmary, the big state hospital, where you'll get that done. So, the people do have private insurance, but it's nowhere near as ubiquitous. And, at best, it gives you a little bit of an edge on a waiting list, perhaps, or a nicer room in the hospital or something like that. But it really isn't critical, as it seems to be, as Dr. Osgood is telling us. You have private insurance, you have Medicare, and you have Medicaid, and there's really a kind of apartheid between people in this country when it comes to what kind of healthcare they can access.
Yeah, and my understanding was that even the doctors that work in those private networks in the UK, I think almost all of them just do it to moonlight, and their primary source of income is in the NHS.
Yeah, my father had a private practice, but the majority of his work was done in the National Health Service. He basically would work. I forget. I think he was on a 3/4 contract, and then for the quarter of the time where he did his private practice, he just rented the National Health Service's equipment and then did a private practice on the side. So these kind of systems exist, but obviously they're just less critical, because it really becomes a high-end thing for a very rich person to do, which there's problems with that, with a two-tier system. But if you're even a relatively wealthy person, you go on the National Health Service. Why would you pay to be in a slightly nicer room when you can just get perfectly good healthcare from the state provider? And my dad gives the same healthcare to the private patient as he does to the National Health Service patient. It's just that the National Health Service arranges the waiting list for them, whereas in the private service, the doctor arranges the waiting lists.
Right.
What's interesting too about when researching the history of how we even got the Medicare in 65, during the New Deal, there was a doctor who was doing all this research because they wanted to have a Social Security, right? They wanted to roll out Social Security, and a healthcare plan was going to come out of the Social Security Administration. And this doctor that was doing the research found that, people are getting sicker, and a good worker is a healthy worker. So we should have sort of socialized medicine, because these workers are going to need it. Keep in mind, there's mines that are still happening. We're coal mining at a much different level than we are today. Black lung is a thing. So this doctor was like, look, man, you got to keep these workers healthy. Let's get a healthcare plan. I was like, no. The concern right now is unemployment, and we need unemployment insurance and Social Security. So
it's almost analogous to how they came up with the concept of weekends. It's like, hey, you got to give the workers time to go buy the shit that we make.
But can I ask you then, as somebody who works in the healthcare system in the United States, what do you see as the biggest obstacles to this process of healthcare reform, of us getting to some form of universal healthcare? And I would note the system that is being proposed in the United States is not like the British system. The British system is completely socialized, nationalized healthcare. We're talking about a national health insurance system where I believe doctors would remain, private practitioners. They wouldn't be employees of the state necessarily.
Mm-hmm.
So, what are the big groups that are opposing this reform, and how do medical practitioners, medical doctors, nurses feel about this? Because I'm sure there's a diversity of opinions. So how do people see this problem?
Yeah, great question. So I think pretty obviously there's just sort of an electoralism dead end here, because you have even the Democrats who, a majority of them are looking more to so-called build on the ACA and would be opposed to a universalized system or Medicare for all. And then, of course, you have the Republican Party who's going to do everything they can do to fight it. But of course, you have a biopharmaceutical industry and a private health insurance industry and lobby that both gives unlimited amounts of money to our lawmakers, and they are advertisers and funders and contributors to our main source of information, which is legacy news media. And so they get to very much be involved in how the narrative gets crafted from that standpoint. And then, of course, you have, organizations like the American Medical Association, who still to this very day are very opposed to anything that is going to turn the field of medicine less into sort of a consumer business and more into a function of the state. And so it's frustrating that no matter what we do and no matter how popular the concept is, when ordinary Americans are polled, through the traditional levers of electoralism, it's a dead end, and which is why I'm so interested to talk to you guys about coming this from a sort of revolutionary standpoint and a sort of a direct political action standpoint, what people can do, and I have some thoughts on that. But within the medical community, I think there's certainly a lot of conservative doctors who, tend to be some of the older doctors and nurses. But I think especially with younger, more millennials and younger people becoming doctors with more sort of left views. And I think overall in the medical community, it's becoming much more popular. There's a lot of frustration when you're trying to navigate this system where somebody might have Medicare, somebody might have private insurance company A, B, Aetna, Blue Cross Blue Shield, whatever, and they all have their preferred formularies. They have their preferred medications they prefer. And so if you're not familiar with those, you could end up incurring unnecessary costs on your patients because they prefer drug X, you prescribe drug Y, and you may, so now you're dealing with those kinds of hurdles. If you are in private practice as a doctor, you have to hire either a billing company who, has to credential you with every single individual insurance company so you get reimbursed, plus Medicare, Medicaid. No one wants to do that on their own. So that's cost going out of your pocket. Or you just go to work for a group and they're sort of already plugged in with these groups. And now they're paying you a salary, but they're raking in on your efforts and they're billing for your work. And what that basically turns into is your job as the doctor now is, taking care of the patient, but really it's about producing documentation that's going to justify maximal billing to maximize revenue in order to cover all this overhead. And so if you actually look at the job growth of actual clinicians versus since like the 1970s till now versus the job growth of like administrators, finance people, coding and billing, all that sort of non-clinical, but that's exploded. And job growth of actual clinicians has remained pretty flat. And so as we've taken the path of technocracy in sort of, I guess technocracy is the best way to put it, the Affordable Care Act, building on the ACA as opposed to just a simple single payer system, it requires all these additional players to help the actual providers of healthcare, whatever kind of medical entities, hospitals, to use all these human resources to try to navigate that system and make sure that the maximum amount of revenue is coming in. And so that's what doctors are spending their time on. And that creates a problem because now it's like, okay, we're gonna allot X number of minutes for you to spend with each patient. Well, so now you're rushed. Now the patient feels like they're being rushed. Your job is, again, to produce this document that's going to be able to go and get sent off to that payer to be reimbursed. And so you are basically a data entry clerk trying to fill out forms in order to, document your visit with that patient. versus actually making the patient the primary focus of your attention, which is what a clinical encounter is supposed to be. You have to do that, and at the same time spend all your time navigating these drop downs and click boxes and all these different things that have been designed to just basically the purpose of it is to make the patient look as complicated and sick as you can make them look, because that's how revenue gets maximized. And this is what doctors are being forced to spend their time on. Versus if we just had a simple single payer system, I think it would eliminate a lot of that. And I think the quality of care would get better. You'd be able to spend more time with each individual patient, not have to deal with all those hurdles. I think satisfaction would be higher, administrative waste would be less. And I think in many ways it would pay for itself. As far as patient satisfaction, worker satisfaction, clinical outcomes. And we see this when we compare how we do as a country compared to the other OECD nations. But, there's no political will and there's no electoral pathway to getting there. So it's very frustrating. And you see patients get hurt by it every day.
And to give people like an idea of how long we've fought as a nation just to get to even where we are today. Again, 1911, the conversation started about having nationalized healthcare. FDR was too scared to roll it out because of the pushback from the AMA. Truman couldn't get a floor vote on it in the 50s. And then you get what we have today, which is, Medicare for 65 and above and Medicaid for the indigent. With the LBJ, Great Society Administration. Even Kennedy wanted to roll out. He was an endorsee of a nationalized healthcare plan in '61. So, decades we have been talking about nationalized healthcare, and the neoliberalization of healthcare is what I've been seeing as we hit the 90s with the Clinton administration, and then definitely in 2003 with Medicare Part D.
Mm-hmm.
So question number one for a strategy to get us to some sort of socialized medicine, what is the first step that we should take, in your opinion?
Yeah, so I think the first thing we have to do, and I think a big error that gets made is that when you look at these polls where, whatever it is, 80% or this, 80% of Democrats and even, 55% of Republicans or whatever, all, would be in favor of a national healthcare plan. And I think when you see stuff like that, it's easy to get tricked into thinking that the legwork is done as far as messaging. And I disagree with that, because then you have to take it a step further and say, well, okay, you'd be in favor of the concept of that, but will you actually put a vote to that? Will you not vote for somebody who opposes it? If somebody comes to you and says, sure, that would be nice, but hey, I have a plan we could get done faster and implement more quickly and it's more pragmatic, can you drive voters away from it that way? And is it possible to, I guess, kind of just scare people away from it with counter messaging? And so far, those things have all worked. And so I think when we just say, well, the will is there, everybody wants it, and now it's just like we have to force a vote. I think it ignores not only that, yeah, sure, there's sort of electoral dead ends there, but I think we overestimate the extent to which the messaging is done. And a lot of people, when you talk to, normies about this topic, what people are concerned about, it depends on your audience, it depends on who you're talking to. So if it's somebody who's age 65, and you are somebody who wants to turn people off from universal health care, well, you can just scare them and tell them, hey, you've got this great Medicare. Now it's going to get watered down and given to anybody, and it's not going to be as good for you anymore. Everything's going to change. If you are trying to get somebody who's in a union to go against it, hey, you fought so hard for this great health care plan under your union, it's going to go away for you. If you're talking to somebody who's more maybe libertarian leaning, oh, worst thing you can say is, I'm from the government, I'm here to help. The government's bad. They're trying to take over everything. The government doesn't run things correctly. If you're talking to doctors, your pay is going to go down. If you're talking to people who just are resistant to change, this is going to just completely do a facelift of American healthcare, and you're not going to recognize it anymore. Don't you just want to take more cautious steps? And I think you have to be able to kind of debunk those things one by one. And I think I shoot the shit with so many different people about this, patients I have, anybody else, and just get their thoughts on it. And I think the biggest myth to start with is that the ACA changed healthcare, and it changed delivery, and it changed it in ways that people do not like.
Well, let me
they
ask
just
you
don't.
this.
Yeah, go ahead.
This, since we're talking about the ACA and strategies, do you think that the ACA was the perfect program to shut up any talk whatsoever about socialized medicine?
I think it was very effective in doing that. Yeah. And it put people in a tough position, because if you want to change that, now it's like, you're against Obamacare. You're a traitor to the Democrats. You want to rip up Obamacare. You're just like those Republicans who want to tear up the ACA. It's actually pretty brilliant on their part. And what the ACA, I mean, look, inarguably the ACA did some very important things. It did some great things, and it definitely saved lives. But really, it was almost like meant to insulate people from a horrible, toxic landscape of healthcare, as opposed to change the underlying landscape. And, people, when they talk about the ACA, they're generally going to talk about the Medicaid expansion, staying on your parents' insurance later, the exchanges, the rule against pre-existing conditions, right? Like the state, supplementing state Medicaids. Like, there's a whole side B to that really largely drove changes in healthcare delivery that a lot of people, unless they're either policy wonks or they're involved in medicine, things like ACOs and, the MIPS and PQRS payments and all the different things that went in to the requirements that, healthcare practitioners, hospitals, and, the billing and the payments that if you're not involved in that, you don't really care. But what happened is that, and then the other one that's really important is what we call mandatory meaningful use criteria of EHRs. And that's actually huge, because the electronic health record industrial complex, in my opinion, is a big part of what's driving what's gone so wrong with healthcare since the ACA was formed. And I think anybody who's, from this country who has been going to the doctor has probably noticed that in the past several years, you probably remember there was a time that you would go to your doctor's office and you sit down and they kind of look at you eye to eye, and you feel like you had kind of a warm connection, and they looked at you. You were the center of attention. You had this kind of healing relationship. And now you probably notice that when you go to the doctor, it's this.
Yeah.
Right. Yeah. Oh, okay. Yeah. Boilerplate. And the center of attention is a computer. They're asking you some questions and they're entering things into a computer, and there's a sort of a loss of that human interaction that used to exist in medicine. I think that's been bad for outcomes. I think it takes away from the kind of attention that doctors should be giving to patients, but it has been imposed upon doctors because that is meaningful use of electronic health records. Now, look, sloppy handwriting is bad. Electronic health records aren't inherently bad. But if you look, for example, at what they did in Canada with EHRs, it was nationalized, publicly funded, and pretty standardized so that everybody can use it. It was actually geared to support clinician workflow and to work with doctors and patients. The EHR industrial complex in the United States, who are they serving? Well, they're serving the billers, the coders, the insurance companies, those who want to be able to extract as much. They're serving basically the hospitals and the healthcare systems that are trying to bill for your services. So everything in there is built around making the doctor and the nurse, whoever it is that's providing the care, enter things in a way that's very nice, codable. Everything's in a nice box. Everything is designed in a way so that they can just extract it, package it up, and send it out for money. And so they've got your doctor basically, or your nurse, your clinician, whoever it is that's seeing you, working primarily to produce document output that's creating money as opposed to the best clinical outcomes. And so I think anything we talk about that's going to really work and drive not just decoupling healthcare from people's financial situations and taking hardships away from people, but actually producing better outcomes and better satisfaction for patients is going to have a revisit of EHRs. And I think if you actually talk to people and kind of point this out and say, look, Obamacare round one made all these changes that, think about that. Remember, you used to go to that doctor and you had that kind of interaction. Now this is what you go through. Obamacare round two, the Biden care, building on the ACA, is going to double down on that because you're going to bring more people into the system without universalizing it. It's still going to be for profit. It's still going to be neoliberal. So it's going to be even more so. There's going to be more complexities introduced because they're not going to squeeze the insurance companies. they're going to squeeze the doctors, they're going to squeeze the patients. And in my opinion, if we go down that route instead of going down the universal healthcare route, I think a decade from now, we're not even going to really recognize medicine. I think it's unlikely people will usually get to see doctors. I think medicine will be more doctors managing teams of like PAs and NPs that see patients, and you'll rarely see your doctor. There'll be very brief visits. I think if you talk to people in a way where it's like, actually going forward with Medicare for all, I don't think will be radical change in your healthcare experience. I think it's the only chance we have of preserving it. And it's this further neoliberalization of medicine and building on the ACA that's going to more radically change the way you experience healthcare. That makes people stop and think about that more. So you have to break up that phony narrative that it's Medicare for all that's so radically going to change everything. I don't buy that for a second in terms of the actual patient experience. And then, of course, it's nonsense. Like if you're a union and you don't have to worry about negotiating good health care, you can put your bargaining power to get other great things for yourselves. Raises and better working conditions and whatever else. And
PTO.
Yeah. And, the way that they've been able to prevent labor from moving around more freely is tying health insurance to your employment. There are a lot of people who might want to leave the job that they're at, go do something else, go try an entrepreneurship, maybe even take a little bit of a sabbatical, take some personal time, whatever it may be. They're miserable. They can't. Why? They have medical needs and they have a health insurance plan through their employer, and that's keeping people in line. And I don't think I think there's forces at work that don't want to change that. And this private health insurance industry is obviously this multi-billion-dollar a year industry that doesn't want to, lose its grip on basically siphoning money out of a system. So, I think that if you bust up the narrative that it's actually Medicare for all that's going to be so radically changing of you, the user or the consumer of healthcare's experience, I think that's a good strategy, and that's something I found to be effective when I talk to people about this.
So we have a super chat on the screen here. So the super chat says, and it's from JB, a regular. To what extent?
Appreciate you.
To what extent did Obama's attachment to the ACA make it the silver bullet for the healthcare industry? Obama is treated like FDR / Social Security. What are your thoughts?
Security is a huge, huge difference than the ACA. I think, and I definitely want to hear what Dr. Osgood has to say about this.
Call me Eric.
Well, say no more, Eric. Now you're going to get even more nicknames that you went down that road. But I feel like his attachment to it made it, because I remember early on, it was being billed as socialized medicine. And that seemed to be the messaging that was coming through to mainstream media, especially the more right-wing side of it with like Fox News, was this is just going to be like Canada, and Canada's a nightmare.
And people were going, I want the government's hands off my Medicare.
Yeah. Which again, when you go back to these original arguments for why we have no socialized medicine in this country, the first argument is that medical care is a personal matter and the government shouldn't be involved. But as we now know, it was more of, I don't want to be on the state's payroll because, I don't want to be a public servant, which was the messaging you were getting from doctors. Right. As medical expenses got higher after the war, you're looking at people paying 44% of their income to medical expenses. Private insurance got better because, unions were stronger at that time. There's more private insurers. And that becomes kind of the problem why you can't get any sort of public goods medical coverage, because you have all these other hands involved. And in my opinion, Obama kind of didn't push back too hard on the idea that people had that Obamacare was going to be the same thing as people got in Canada and the UK. Mm-hmm. And it's nothing like that.
No, not even close.
and I think something Eric said is really important, especially to people in the left sphere who exist purely online. It's about, you tell people, everybody should have healthcare. No one's going to disagree with that, right? It's like people shouldn't die on the street and things like that. If you ask somebody that, but what really matters is when you get down into the weeds, because there are people who are protective of the ACA. There are people who if you explain it to them, it sounds like a good idea. And then there are people who, if you explain it to them, they say, yeah, universal healthcare would be a great thing, but I have other political priorities. Like, I don't want to support abortion, and I don't want the government paying for transgender gender reassignment surgery and things like this. So you have all these kind of reasons that people might give, and probably a lot of it is just like, I've got good health insurance, and I'm worried that if something happens, I will lose, it'll go away. So I think people who think, like you said, Eric, that the legwork is done, frankly, have no business being political commentators.
Thank you.
Yeah, because I go around here in Springfield, Missouri, and I can talk to nearly everybody would agree with me if I tell them about like a better system. It's better in terms of being more humane, and it's better, as you've kind of indicated, and I've often thought about this, it's better in terms of the kind of medical treatment you receive, because you're not you don't have to make a medical decision based on your financial situation, and the medical doctor doesn't have to give you a treatment based on what turns out to be more profitable for him. My father, when he worked for the health service, he's like, I don't care how much it costs. I give him the treatment that I think is medically best. There's no financial incentive. Like, we look at the opioids crisis. This was purely manufactured by a perfect storm of a very predatory pharmaceutical industry and a privatized healthcare, which made it profitable for certain medical doctors to do these prescriptions. So, you can make all these arguments, but we have to make those arguments concrete. Asking someone if they think, everybody should be given a chance of life is like really, misunderstands the political question. People think that Medicare for all is extremely popular, and it isn't. It isn't as popular as people think it is, because the problem is not the abstract, it's the concrete. And, as you come towards a concrete solution, then that's when people start worrying and belly aching. So, you talk in the abstract, we're going to bring universal healthcare, everybody signs up. Suddenly, when people see the change, the innate conservative nature of people, especially people who are in a privileged position, comes to the fore. So I think, there's a lot of delusions, especially in the left media sphere, because you have people who don't really interact with, interact with like regular people on a regular basis, or don't talk to people outside of their like social circles. There's a lot of delusions about the concrete political obstacles. It's not simply that the Democratic Party and the Republican Party are on the payroll of the insurance industry and the private medical, the pharmaceutical industry. It is that there is a reticence amongst the American public, many of whom hear all these horror stories, which are like largely fabricated about socialized medicine in other countries, and then think that they're living in paradise. Like, this is the biggest trick the American ruling class plays on people, is tricking Americans into thinking they have the best lives in the world, and there's no other better system outside. You even go to like the social democratic sort of states in Europe or Canada and places like that. It's like, it's better it's just living standards are better. It's still not perfect. There's still many problems, but at least you're not freaking out that you're going to get cancer and then you're going to have to decide whether you're going to just let yourself die or burden your family with all these costs.
I mean, that was one of the things we talked about on the show when we had our bit of a Afro-pessimism conversation about the New York Times article that came out about Black women in the healthcare system. And actually, I will save that for the bonus half because we got 3 minutes left. But I definitely want to get Eric's take on that, because one of the things the article didn't talk about at all, as is giving you these horror stories of Serena Williams not getting the proper coverage in an emergency room, is that the majority of the women they were talking about were on Medicaid,
right?
Which again is the healthcare for the indigent. It's as Dr. Eric said earlier, motherfuckers don't want to fuck with you.
Pretty much. I couldn't have said it better myself. Motherfuckers don't want to fuck with you.
And states,
I fuck with them, but
and conservatively controlled states,
and it's
make that care even worse.
As
purposely
by the states.
Yeah.
So if you're in a conservative state, that's your ass. I'm in California. It's slightly better, but ultimately for the people that are in other states, maybe like, I don't know, Missouri,
baby. We live here in Missouri, having a good old time, baby. I'm trying to work on my accent around here so I can fit in.
Don't do that. People will lynch the shit out of you.
Hey, baby, you pretty. You got a pretty mouth.
And just to touch on the pandemic again, I mean, the pandemic obviously put these sort of massive fiscal burdens on hospital systems, and I saw firsthand, working in a community-based hospital system where we have a lot of people who are uninsured, undocumented, undomiciled, and you had people who couldn't return to normal oxygen levels, and this takes weeks sometimes. And so if you are a privately insured person with a specific amount of or a certain amount of means, we can get you home oxygen and we can get you home, versus there are people that had to sit in the hospital for weeks and weeks and weeks and weeks and weeks. Why? We have no way to get them oxygen. They don't have any money. They don't have any health insurance. If they're undocumented, we have no way to even get them Medicaid services. If they're here sort of legally, so quote unquote, we could potentially, if we're lucky, get like some long-term care facility to accept them as like a Medicaid pending. But we expended so many resources with this sort of logjam of people for whom we just couldn't get the basic resources they need to be able to go home. And so how many costs were wasted, and then people sitting in the hospital unnecessarily, all away from their families, isolated in a respiratory isolation room for all this extended period of time. Why? We had no means to get them oxygen so they could go home and be able to breathe. And I think the next wave of this is going to be a major fiscal hit on more of the ambulatory care setting because of COVID long haul, which is something I've been involved in, with all these people who are getting chronically sick, who have recovered, and all the specialty visits they require. The U.S. healthcare system is not ready for this. The amount of healthcare utilization that's going to ensue, the complex illnesses that are going to ensue, and without people being able to, have adequate insurance in this two-tiered system, it's going to be largely along, in some cases, racial lines and socioeconomic lines, where people who can't get to these private specialty offices are just going to suffer with long COVID, and people with the means, the haves versus the have-nots, the haves are going to be able to go to all these subspecialty clinics and maybe get some help that they need. Even that's going to put a huge burden on the system. And so there's going to be a lot of injustice there too. And so, you mentioned something like, might this pandemic somehow be like a gateway to get people more in favor of going towards universal health care? The constraints going forward that the aftermath of this pandemic is going to put on us might lead us to some extent down that path, just because I don't see how our current landscape is going to handle these issues.
Well, we're going to take a deeper dive into some of these questions on the after hours. We're also going to have a discussion about 80s thrash metal with the good doctor.
I don't care for 80s thrash metal.
You know what I don't care for? Your beard.
Ooh. Well, people should remember.
Shots fired.
Like and subscribe. Ding the bell. Leave a comment. Leave a comment. Jason gets upset about the mean comment, so leave a nice comment, because he'll like message me and be like, "Look at this guy writing a mean comment." I'm like, dude, don't worry about it, man. Like, don't worry about it.
Totally screenshot all the mean shit.
He screenshots them and he sends them to me
with Gene and Pascal and Cuba. I do.
And also, check out the merch store. Right, become a patron if you can. It really helps the show. And anything else important to remember? If we get to 1,000 patrons, Jason will do a live show where you get to meet Pascal in person and shake his hand. We're gonna make Pascal. He's gonna be a star, right?
We're gonna video also Pascal getting in shape for the live show. It's gonna look like a Rocky IV montage.
A Rocky montage. Yeah, we're gonna.
Montage.
Yeah, and pick up some merch because I'm wearing the This Is Revolution hat, and
I just bought a sweatshirt.
Oh, you bought a sweatshirt? Awesome!
I did.
You gotta take a picture so we can put it up.
I will.
Yep. Oh yeah, definitely.
So Eric and I are going to have some fun talking about metal and crazy shit. We're also going to talk a little bit more about strategies for getting to Medicare for all and just the problems that we have getting there. Also, we have some great shows coming up Saturday. Gene, you're coming on Saturday, right?
Yep, we've got Harun Yilmaz, a good personal friend of mine who is a historian of the Soviet Union. He wrote a book comparing the nation-building project in the Ukraine, Azerbaijan, and Kazakhstan. He actually has some really good stories about being in the archive. Like they wouldn't let him photocopy things in the archive in Azerbaijan, so he like hid in the toilet and took pictures of them. And so he's going to be talking about the history of nation building in the Soviet Union, how they dealt with the national question, and then talking a little bit about some of the misconceptions of the Soviet Union, some of the positive legacies of the Soviet Union, some of the negative legacies of the Soviet Union. So guys, don't get triggered.
Most positive legacy of the Soviet Union? Cell phones.
There you go. Tetris
comes from the Soviet. There you go. Tetris
comes from the Soviet Union. Yeah. So
winners, as far as I'm concerned.
So we're going to be doing a deep history dive with Harun. He's a pretty funny guy. So I hope you guys all enjoy it.
So on that note, we are out. Eric, I'm going to send you the new link. So where's the going out music? Oh, here it is, I think.